That was really cool. My brain is cooking, thinking. I'm surprised that Ain didn't say 1 instead of yes. I thought that was going to be the answer to that, not 0 or 1. The next session is on global models of healthcare innovation and outcomes measurement. And we have 3 speakers and time for some questions. We have Stephen Flaherty from iCHOM. If you could come up to the stage and take a seat, and I'll invite you to present. Alexis Wise from Mars Center. Alexis, thanks for joining us. And Zahav Udin from General Electric is here to join us. We've invited these individuals to talk to us, bringing the perspective on outcomes measurement. Once you saw the potential capacity of a digital system operating and data being shared, you can imagine all the different opportunities there are for advancement, as highlighted by Ain. Of course, you're going to want to have the value at the end measured by real outcomes. And then how will we possibly generate an investment paradigm that would allow this to come forward? And so we'll hear a little bit from Alexis on that topic. And then General Electric, of course, is a company that makes industrial technologies of all kinds, all different sectors. So clearly they must be thinking about this and trying to understand how to tackle it. So I'd like to invite and join me in welcoming Stephen Flaherty, from the Director of Standardization and Benchmarking from an organization that was produced through a collaboration with Harvard specifically to come up with standardized measurements for outcomes. Stephen.
All right, let me check this. Let me check this to make sure it works. Oh, we're good. Forward, backwards. We'll get here. There we go. Okay. So thanks for having me today. I appreciate it coming up from Boston. I was never been to Toronto in my life, even though I grew up in the Boston area, which I feel really sad to say that I'd never come to Toronto before, because it's an amazing city. And as a hockey fan, I've been to Montreal and seen the Bruins play up there, but never come up here. So I feel like I've let you guys down. But I'm happy to be here, so thank you for having me. I'll talk a little bit about the history of iCHOM and what we do at iCHOM, to give you the background that I've actually just started at iCHOM in the last few months, although I've worked with them for the last couple of years. My background is in oncology. I worked at Dana-Farber in Boston for a number of years, looking at value, but also looking at the regulatory policies around how we capture data, how we develop measures, and how we can look at performance and find some quality in there and actually do some improvement efforts in that. And a lot of my work has been in bringing collaboratives together, and that's what iCHOM does too. iCHOM really collaborates with a number of institutions around the world to try to bring together thought leaders in the field. iCHOM is the International Consortium for Health Outcomes Measurement. They were founded in 2012. And they were founded by 3 individuals, 3 thought leaders. Michael Porter from Harvard Business School, who, if you're familiar with Michael Porter, is very into competitiveness and strategy. And with Teesberg, had a great book that came out that talked about the value model and the value equation in healthcare. We also have Stefan Larsson from Boston Consulting Group and Martin Ingvar from the Karolinska Institute. And those folks all got together and they really started to think about, from an academic perspective, how can we look at value in healthcare and in a healthcare setting? So this is the famous equation. I think it was referenced earlier, value equals outcomes over cost. From the iCHOM perspective, I'll specifically state that we look at outcomes as patient-reported outcomes. So instead of simple, I hate to say simple, but instead of simply looking at clinical outcomes that might be physician-reported outcomes, we want to ask the patient along the entire course of their care for a certain disease, outcomes that are specific and interesting to them. And as a public health person in my background, I think of the QALYs and the dailies that you might think of when you look at quality-adjusted life years or disability-adjusted life years. And we look at the cost of the outcomes is not just for one fee-for-service or one piece of capitation, but for everything, for the entire piece of that. Being from the United States, we think about things like an accountable care organization being paid for the entirety of a care session here. So how iCHOM does that work is very interesting. And I think one of the reasons why I moved to iCHOM was to try to see where we're going to go with this. We're trying to put the rubber to the road here, because it was an academic exercise to think about value and to actually start to look at value in healthcare. But to do that, it takes a lot of work. iCHOM has become very well known for and is very good at probably the first part of this green arrow up here, and it's part of the core mission of what we do, and that's defining the standards. We have a number of standard sets we've created for specific disease conditions, where we bring in individual physicians, patients, and other individuals who are involved heavily with specific diseases, breast cancer, prostate cancer, hypertension, diabetes, for instance. They come together over about a year, and we go through a process of individual calls where we'll talk to those individuals and say, what are the patient-reported outcomes, or what are the clinical outcomes that you find to be the most impactful and most important for these people in these diseases? And that takes a long time. It's a lot of voting. There's a Delphi process to vote on these, and it can be very contentious. I can come up with a standard set of measures that should be taken in that's hundreds and hundreds of measures and trying to pare those down. And as we've been criticized in ICHOM sometimes on having too broad of a standard set or proprietary or non-proprietary, we've really thought a lot about that and said, can we get to minimum standard sets and minimum sets of information to capture? You see this with a lot of the different tools that are out there, the PROMIS tools and disability index tools as well. The next part of that, after we've created these standard sets, is really capturing that information, seeing how it works within local governments, within individual payer organizations, taking that information, and then trying to take that data and benchmark it. After that, we actually trying to look at outcomes transparency. And in outcomes transparency, we work a lot with health settings as well as media, publish academic publications to push this out there and to talk to folks about it, to say, this is the burning platform for us is to move forward. In the interest of time, I'll go through some of the things that we're doing and how we're getting there, but you guys all have access to these slides, I hope, afterwards. So you can learn more about how we try to enable a lot of those actions as well. We're a small group of only about 25 employees at ICHOM, half of them in the Boston area, half of them in London, and many of them very multinational. So people working in Mexico, people working in Australia and regional areas in particular. So we try to do a lot and understand that we only have the capacity to do so much in our core mission, but when we're trying to enable others to work with us, that's a big aspect of that. I talked a lot about how we've created standard sets and what we do for our standard sets. You can see on the slide behind me the standard sets that we've created over time. We started off in 2013 with our first set of standard sets, and our goal was to really cover a lot of the disease burden. The World Health Organization's report on the disease burden and what is impacting lives across the world, to get to hitting at least 50% of the disease burden. And we looked at some of the big hitters here: heart failure, stroke. But we also spend a lot of time on things like cancer care, and we've moved forward and looked at things that are a little bit more particular, but have just as large an impact. Things like cleft lip and palate or inflammatory bowel disease. We continue to work on developing standard sets, and that really has been kind of our bread and butter at ICHOM, is developing standard sets, and now moving to do version 2 of those, update those, look at the data behind those, and see who's actually implementing and utilizing those standard sets. This is a great slide, I think, to show the global reach of ICHOM. These are the individuals so far who've worked on our different working groups, and each one of the colors on the little dots relates to a different standard set. You can see that we have lots of buy-in from the US, from Canada, from the UK, from Norway, Sweden, et cetera, also from Australia. But we've got people not just in those areas, but across the world that have been involved in standard set creation. And our goal is to bring in not just a North American focus or not just an EU focus. We want to make sure that when we're looking at patient-reported outcomes of care, that the patient-reported outcomes span beyond an academic medical center or a place that has all the money in the world, knock on wood, to deal with a problem. One of the things that we're trying to do as we move forward is to be not so segmented and simply just look at one disease, but our goal is to look at the intersection of multiple diseases. In the coming year, we're actually doing a lot of work on an overall adult standard set. So not just looking at breast cancer, not just looking at hypertension, not just looking at diabetes, but looking at the intersection of where many of our sets come together for overall adult health. And doing the same thing for a pediatric set, to look at pediatric overall health. And you can see that our hope is that by doing this, we'll be able to capture a larger core set of information for any individual that we work with. Part of that's driven by the people that we've worked with and the institutions that we've worked with. So we do a lot of educational offerings. We go to healthcare settings, we go to governments, the NHS in Wales. We've done a lot of work in the Netherlands, for instance, and done a lot of educational offerings to talk to them about value-based healthcare. Depending upon where they are on their journey to try to get to value-based healthcare, it might just be a simple education session on what value-based healthcare is, giving them some background information and showing them some use cases of that, or it might be really getting into their information of how their government structure works and how this can be incorporated into the government structure. We've gone in and done anywhere from 1 to 5 to ongoing 1 to 5 day workshops to ongoing workshops with different individuals and organizations. The next part of that is measuring these outcomes, right? We can go in and talk about value-based healthcare, but like I said, the rubber hitting the road is the big piece here. If we can see this in action, it makes a big difference. And I think that that's where a lot of us have stalled. We talk a lot about this. It's a really interesting thing to do, but there's small pockets that are doing certain things. And many times you're doing this and you don't know about it outside of the small sphere of influence that you have. So we've done a lot of work in trying to help providers measure what they're doing. And we have at least 43 organizations, probably more, I would say now, that we've actually worked with to start to capture data and to look at their outcomes as a whole. A lot of that work comes into our benchmarking program, which I was brought on to be the director of and to actually grow and expand the benchmarking program. Over the last year and a half, we've done a lot of work with our data partner, ICON, out of Dublin, to create the ability to capture data from multiple sites across the globe, and these span 5 continents, sites across the globe, for cataract surgery as well as for hip and knee osteoarthritis, so hip and knee replacement, unilateral or bilateral. We're capturing a number of data points from institutions so we can look at those institutions that are trying to capture patient-reported outcomes as well as clinical outcomes and see if there are differences across our sites and try to find best performers. Created some visualization tools so that they can dig into their performance versus benchmarks, dig into their own performance and actually see how they're doing. And for us, I think, just like you talked about, Barry talked about earlier about monetizing some of the things that you're doing. We have a lot of intellectual property and ideas, and we get a lot of information. We don't do a great job of monetizing that. We've only been around for 5 years, and our goal has really been more on the academic side and publishing and pushing this forward and sticking with our burning platform. But this is an opportunity for us maybe to become more integrated with more healthcare systems and do more work there. In my last minute, I'll go over the last few slides we have here to give you some more to think about and to tweet about and text about and ask questions about later. But we've come into a partnership with the OECD. They have a very vested interest in making sure that there is value in healthcare, and all the organizations that are a part of that understand that the OECD supports the work that ICHOM has done, and we support the idea of value-based healthcare. So they're really pushing forward ICHOM and patient-reported outcomes as a great way to look at value and to understand how we can capture better value. In the next year, we'll actually look at the cost side of this a little bit more, which I think really starts to bring things full circle, not just capturing patient-reported outcome data and clinical data, but cost data and bringing that into a repository for our lung cancer and our breast cancer sets. And we have a number of institutions who will be sending us that data, working with a few people across the globe on that. But we're always open to more and more institutions being a part of that. We've also done some work to look at commissioning and procurement programs, whether this looks at bundled payments and working with organizations on how they can structure bundled payments to get to where they want to be, or when it comes to contracting and suppliers. The last piece here is, and I'm trying to go through these very quickly so I stick to my time limit here, I apologize, but I'm from Boston, I talk fast. The idea of medical education is an aspect of this, I think, and part of it is getting to know what value-based healthcare is, but part of it is getting to know how you can think about that as a clinician. We have an education department at ICHOM, and many of the individuals that work there are physicians and have worked in this education space before. So creating an online ability to spread the message, to understand how to do this and how to implement this is a big part of our work in the coming years. And with that, I will step away, and we'll do questions later.
Yeah.
Okay. Thank you.
Thank you, Stephen. Lots of food for thought. We'll talk about this in the panel.